echo imaging. We are going to have the case-based discussion. I'm Dr. Orapon, and it's my great privilege to welcome you here in this session. Our panelists will be Dr. Helen Thompson, Professor Vanny Mannon, and Dr. Rangslit, okay, from Chiang Mai University. And we'll have cases presented by Dr. Thawai and Dr. Pandit. We'll first start with our first case. Dr. Thawai will present about a case of a failed post-mitral valve repair.
Okay, thank you, Dr. Arapon. Okay, my case is 65-year-old lady with underlying of type 2 diabetes, hypertension, and dyslipidemia. 3 years ago, she developed non-STEMI. The CAG showed triple vessel disease. He underwent CABG, which was the limb arteriality, SVG, sorry for the misspelling, to D1 and to circumflex and the PDA. At that time, the echo showed mild to moderate MR with a good RV function. 1 year before admission, she developed tornado breath. The echo showed severe MR from frail PT, A3, P3, and C2. So he underwent mitral valve repair using suture plication of 3TA3 and C2 area, as well as the closure of the cleft at P2A2 and put the 28 CE physio annuloplasty ring. 2 months prior admissions, she had recurrent chest pain with positive stress echo. At that time, the CAG showed only patent lemur. All SVG are occluded. She underwent PCI of left main to LCX with drug-eluting stent. At that time, the RCA received good collateralization from the left coronary artery. 2 weeks before admission, she had recurrent heart failure without chest pain. He admitted into our emergency room for many times. At that time, the current medication include dual antiplatelet, cadherin, carvedilol, statin, furosemide, metformin, and omeprazole. The physical examination showed good blood pressure, rising JVP, and 5 crepitation, both lower lung, soft S1, normal S2, and panhystéric murmur, grade 3/6 at the apex, radiate to axilla. There's no AD bar. Here is her shared X-ray. Okay, and this is her ECG at the baseline. I move to the echo. This her TE. This is the post MVR with ring annuloplasty. When we turn on the color, that's was the severe mitral regurgitation. This is the severe MR with restrict of the posterior leaflet. This is the 3D echo showing the mitral valve. If we turn the volume, you can see the gap of the posterior leaflet area. After I flipped the volume back, you can see that there's the area of malcoaptation between the anterior and posterior leaflet along the coaptation line. This is a 3D color showing the severe MR. We also measure the valve area is the 3.2 square centimeters with a mean gradient of 4.6. So the other echo parameter shows severe area dilation. The area function is 56 without regional wall motion abnormality. All other valve is okay, no precated effusion. So in summary, is 65 ladies with 2 open heart surgery in the previous time and developed the CVMR after mitral repair. The STS score for mortality is 6.4 and 32 for morbidity or mortality. So he has partially improved from medical treatment. And what would be the long-term management for this particular patient? First, redo MVR with bypass surgery. Second, percutaneous edge-to-edge repair, or valve in ring, or medical treatment, or other treatment. I would like to hear from you.
Sure. Now, what size was the ring that was put in originally? The physio ring? It was small, wasn't it?
Not so. 28.
28.
Yep.
So just with your options of treatment, medical treatment probably is not going to help her. She's got severe MR, symptomatic.
Yep.
I don't think you can clip this valve because already it's got a gradient above 4 and the area is less than 4 centimetres squared. So I think you're going to end up having to redo the repair. I think the issue was that probably the ring was a little bit small. You can see on the echo there's a bit of tension on the cords. The pap muscle is still laterally displaced. And so you've got particularly restriction of the posterior, and that's why it's leaking. And I don't see there's any solution other than going in, probably.
She's young, so something needs to be done. I agree, and the ring maybe would have been a good option, but it's looks like a smallish ring, and if you put, and the valve area is only about 3, so if you put another ring, you may be asking for trouble. A valve in ring may be possible. That's not an entirely difficult proposition. The long-term outcome for her would be better if she has redo MVR, but it looks like her risk is considerable, huh? What was the STS risk I saw?
6.3.
6.4.
So either a valve in ring or a redo, surgical redo would be the two options, I think, for her.
Redo. Thank you.
I also agree that it's organic MRI, which is symptomatic, so medical treatment would not be an option. Redo for the third redo would, you have to think, quite a lot about that. And but I think if you look at the 3D image just now, it's not only just not coaptation, non-coaptation along the line, but there seems to be a cleft, remnant cleft. Is that correct?
You can see that in the color top.
And the color on face, yeah. That's straight line up there at about 2 o'clock.
Yep.
Seems you still have cleft that was not corrected.
Mm-hmm.
So I think I also agree that edge-to-edge repair would not be an ideal option.
Yeah.
I would go for an open surgical and bioprosthesis, something like that, or replacement. I'm not sure about repair because she's done so many repair, and I don't want to do risk another, fourth redo or anything like that. I'm not sure.
Thank you. So I share what we have done for this particular patient. At that time, for the redo MVR, after we did a conference for discuss the option for this particular patient. The team say no for the redo MVR. So as Alan say, the percutaneous edge-to-edge repair is limited because the low area and high gradient. So our choice is valve in ring. Do you have any suggestion regarding to the valve in ring? Should we prepare something more before valve in ring?
I only briefly saw the LVOT.
Yep.
It looked okay, but I don't know if you did a CT or not.
Yep. So at that time, we did our CT and we calculate the neo LVOT, and the number is good. So I think the valve in ring is feasible for this particular patient. So we decide to put the valve in ring. So we used the cement tree size 26. I'm sorry, for this ring. So this is. I show you. This is our transeptal puncture, and we positioning the valve. And this is when we implant a valve, we put the valve to the O-ring. This is the result of the valve in ring immediately. Unfortunately, at that time we put the valve. The valve is a bit chilled, so we got the paravalve leak initially. We try to observe this kind of leak for several days, but the hemolysis is persists. So we decide to put another. This is the paravalve leak. So we decide to put another valve.
Inside that valve,
Yes.
what was your valve area like?
Sorry.
Was the big enough valve area by the time
Yep.
you'd done that?
Yep. To treat the paravalve leak, this is what we did. This is a second valve put into the O valve, and this is the final result. This is the 2D and 3D color showing trace central jet mitral valve regurgitation. This is the latest echo showing the good valve function and the mean gradient of 5 millimeter mercury. Okay. So this
Did
is.
you balloon the first valve for
Yes,
the PVL
yes.
and it didn't work? The PVL was still there after you ballooned
Yes.
the first valve.
The first valve. I think because
I think the ring must have fractured.
No, the mechanism. I think the mechanism of the paravalve leak in this patient is from the valve is tube, so some area of
Valve
the
position.
unsealed
Okay.
valve, new valve, exposed to the LV. So we decide to put another valve into the first valve.
So these are Sapien 3 valves.
Yes, correct.
Did you consider putting an amplatzer in that paravalvular leak, just out of interest?
Yeah, but after we discussed, we would like to use this strategy.
Yes.
That,
Beautiful imaging, I might say.
okay, thank you.
Seems like the leak was about a quarter of it.
Yes, yes.
And the patient got hemolysis too. That's
Yes.
another thing that there's no choice.
Patient's doing well.
Doing well right now.
Brain's doing well.
Yeah, the last echo show is the last month echo.
What was her heart rate at that time when you got the gradient? Was she slow or not? It's relevant because, of course, the gradient is
Yep.
flow dependent.
Sorry?
What was her heart rate? In other words, will that gradient hold up when she does anything?
She doesn't complain anything.
Which is a good way to look at it.
Okay. Okay, let's move to the second
Very,
case.
very good, Dr. Tuai. Look like it's just us, so we can just relax and enjoy the case. Okay. Okay. Thank you, Dr. Tuai. Our second case will be from Dr. Bandit. It'll be the theme will be historic moment for low risk aortic stenosis. So many talk in this meeting about the low risk aortic stenosis, and the surgeon they will really try to find upset and find a new strategy to to work on that.
This is not difficult case like the first case. There's low risk aortic stenosis. Okay, a brief history. It is a 78 years old woman. Her Her underlying disease is breast cancer, hypertension, and dyslipid. She presented with progressive dyspnea in the past year, no history or other abnormal symptom. The medication just an ARB, bisoprolol, amlodipine, and statin for about hypertension and dyslipidemia. The physical examination is to show the sign of the severe aortic stenosis, no another abnormal symptom. And this is a chest X-ray, the normal heart size, no significant infiltration, the prominent and calcified aorta, aortic knob. The EKG is just not look normal, no LVH by water in the EKG. This is the echo. There's interesting that she is very small. The alveolar diameter is just about 1.6. The aortic valve mean gradient is around 36. And when you do the color flow imaging, just a small trace the aortic regurgitation. The further investigation, the blood test is looking normal. Coronary angiogram show a normal coronary artery, but the left heart catheter show elevated LVEDP, it is around 30 millimeter of mercury. The gradient across LV and AO is around 45 and 50 millimeter of mercury. Yes. And I calculated the Euro score for the surgery is risk of mortality is around 1%, and the STS score for isolated aortic valve replacement is about 2.5. And we do the CTA to further evaluate the alveolar and annulus. It show the very small alveolar like the echo. The echo is 1.6, and annulus from CTA is just about 1.5 and 1.4 millimeter. The mean annulus is about around 20 and 24. This is a question. What is the best management in this case in about the low-risk symptomatic severe aortic stenosis with small LV annulus? Because we know that we have choices of surgery and intervention like a transcatheter valve replacement. But we know that the alveolar size will affect the patient in the future, because when we use the valve size, it causes a patient prosthetic mismatch, and it causes a worse outcome in the future. This is a question of this case.
How old is she?
78, yes. I will show you the clinical.
68.
78, yeah.
There is no question, if you have a small annulus,
Yeah.
there is data that there is a higher chance of patient prosthesis mismatch.
Sure.
And the other problem with the small annulus like that, how big were the sinuses?
Yeah.
Okay.
The roots, the aortic root.
The aortic root, I'm not sure just about the.
How small or big
25.
were they?
Aortic root is larger than this. I'm not sure, just about 28 around that, or 30. The sinus of Warsaw.
Less than 30 millimeters.
Just about 30. Sinus of Warsaw. Yep.
A surgical aortic valve replacement in this lady is not unreasonable at all. With that low risk, with that small annulus, I think a surgical prosthesis might be better off for her.
I think I'll try to make sure that the symptom is related to the valve to begin with, because the gradient from the echoes was not, not particularly, not very high.
Valve area, I mean, gradients are very deceptive. What was the calculated aortic valve area?
Calculated the aortic valve area is, aortic valve area just 280 millimeters square. Aortic valve area, yes.
That's
Sorry, aortic annulus.
AVA.
AVA 0.8
Yeah.
centimeters square, sorry.
But she's small, right?
Yes, it's too small, yeah.
I'm not sure whether we can follow her. I'm not sure the symptoms related to that or not. And
Yeah, the thing that's a little strange is that on your echo data, you got a mean gradient of about 35,
Yeah.
whereas on your cath pullback, you've got a higher sort of gradient. And that's a little unusual in that often you find the reverse.
I'm not sure because the echocardiogram is a very angulated.
It could be
It
that-
could be from angulation.
Yeah,
angulation.
and you did
Yep.
get and it might be that she's one of those low flow, low gradient paradoxical ASs, absolutely. But it was just a little bit unusual. I guess with this patient, she does have a very small annulus.
Yeah.
It is an issue for TAVI, but it's also an issue for surgery. So if they were going to do that, they would either have to do something like they might have to do a root enlargement procedure.
Yes.
Or they could maybe do something like a Percival, because usually once you excise the leaflets, you have a little more room.
Yeah.
So they would be options. With your CT scan, if we had, you could look at what the perimeter was and look at what the manufacturers say, whether you might get away with it, but it's very elliptical and it's pretty small, and she's got it sounds like she's got a small root, so there would be an increased risk of rupture.
Yes. Thank you.
The AVA index would be what?
AVA index just around 0.6.
Okay.
Yes.
You want to do stress on her?
No, she's got symptoms.
Yeah, she has symptom because she can do daily activity well before and after. Just around, I'm not sure, in past year she developed the gradual decline in functional class.
The other thing you could do, though, is on the CT scan, just look at how much calcium there is on that valve. But I think she probably has severe AS and she needs something done about it.
Do we have a calcium score for her? No. Okay.
Sorry.
The other thing,
Yeah.
did she receive any chest radiation with her CA breast at all? That will.
Just only the surgical and chemotherapy, no radiation. Yes.
So
okay.
we decide.
Okay.
Go.
what would we do? Yes, we try to discussion about the option about surgery, about we push this case in the heart team conference about option about surgery, LVOT reconstruction, decalcification, and use the stainless valve or some sutureless valve to provide the maximal aortic valve area. And the last choice is a TAVR. We provide them a TAVR. The surgeons is okay, but when discussed with the patient, they deny, she fear about the surgery. So we try to use the last choice of this case is use TAVR. But when we selected the valve, we used the neo-accurate, the supravalvular design, because if we use the sapien valve design, this valvular design, where the valve is on the annulus, it may cause some complication. Even when you have no complication like rupture aorta or rupture annulus, it may cause a PPM in the future. So we use this valve design because supravalvular, the valve is above the annulus and may decrease the gradient after we implant it. This is a picture during we do the TAVR. This is neo-accurate. And we check it after that. We use the aortogram to check the aortic regurgitation. There's no aortic regurgitation. And after the complete operation, the complete intervention, the valve did look good, no valvular leak, and the maximum pressure gradient is about 6 millimeters of mercury. Now she come to follow up at the outpatient department. Is she look well, don't have any abnormal symptoms. She can do daily activity like previously. Yeah, this is the finish of this case. Thank you.
Okay.
Thank you, sir.
Thank you. So the next one, Dr. Tawai will present a case. The theme is current challenge and innovation in treating tricuspid valve disease.
So this case is 77 years old female who had type 2 diabetes, hypertension, and dyslipidemia. She had traumatic severe TR and underwent tricuspid valve replacement with 25 magna pericardial bioprosthesis. After operation, she has the atrial fibrillation with slow ventricular response. So the VVI pacemaker was implanted. 2 years before admission, she's still asymptomatic, but the echo showed severe TR, likely from the lead impingement. 1 month before admission, she developed shortness of breath. At that time, the physical examination compatible with the CVMR, which include giant CV wave and pansystolic murmur, grade 2/6, heart breath at the left lower sternal border with trace edema. The medication include warfarin for the AF, aldactone, enalapril, Adalat, statin, and the medication for DM. Here is her chest X-ray showing the increased cardiothoracic ratio, pacemaker leads, and the tricuspid bioprosthesis valve. Her ECG showed the VVI pacemaker, putting that the RV apex. Here's her thoracic echo. You can appreciate the big LA in this big, and mouse and traject MR. For the short axis, we turn on the color to the tricuspid valve, and you can appreciate the severe TR and the TS flow. The TE show the severe TR, and the 3D echo show that the cause of the severe TR is from pacemaker lead impingement. So in summary, she is a old lady with the one open heart surgery for tricuspid valve replacement and develop severe TR after pacemaker implantation. What should we do for this particular patient?
It's probably worthwhile putting in an epicardial system and taking out the pacing lead and seeing what you're left with, and whether that's enough or whether you have to redo that valve.
Okay.
Anyone else?
Yep.
Yes, I would agree with that. That if you think the pacemaker is the culprit, then we should deal with it. Well, you have to make sure this is an impingement or is it perforation or adhesion, or there are other mechanisms for that. But if it's just impingement and they can remove it without much difficulty, maybe you can try that. Epicardial or leadless kind of pacemaker. I don't know.
And many years pass after pacemaker, even though you remove it without doing anything for the patient. The pacemaker was put in about almost 6 to 8 years ago.
You'll know though, like they'll be on the table, you'll have the toprobe down and you'll know at the time.
What? Show me the 3D again.
Sure.
Where is the pacemaker?
It's
And what is the anatomy there? Because we don't. So you're putting a red arrow there. Is that where the pacemaker is?
yeah, but
You don't see it.
Yep.
In other words, is it right at the commissure is a question, or is it impinging on that leaflet?
Well, the leaflet's not moving very well.
Yep.
It does look like it's at the commissary.
Yeah. So that may be a critical. Even if you don't remove it, you can reposition the pacemaker sometimes. We've done that on native leaflets, not on prosthetic leaflets. But on native leaflets, just repositioning may sometimes help with the TR. Not always, can. But this is a tough one because you're not left with many options. A valve in valve may not necessarily solve the problem. It may or may not solve the problem, but that may be the only other non-surgical option you're left with. The other things will be all open surgery kind of thing, or removing the lead, and an epicardial pacemaker is not a bad idea. But manipulating depending on where it is, if it's adhered to the leaflet, then it's any amount of manipulation isn't going to help you. But oftentimes it ends up in the commissure, and that might cause a lot of TR. So I'm trying to wonder where the pacemaker lead is.
So we have two options: either have to open the heart and look and deal with that pacemaker, or if you don't open the heart, what are the choices we have?
You could do as you suggested, you could put another valve in that, sort of sandwich the lead, and then see if it works still.
Then you,
Because it might affect the pacemaker function.
How old she is again? How old?
7 years.
78, yeah.
78.
The other thing I think,
Yep.
well, I think she's, because her RV is still not very, not severely enlarged, and there's no hypertension or anything. I might try medical treatment to optimize that a bit. I mean, we can increase the dose of spironolactone if it's still low dose, not a direct dose. We can, maybe if she doesn't want to go, for surgery, things like that, I think it's not a bad thing to try to optimize medication, I think.
Look like her
But
medication.
we'll have to follow up the RV function pretty well. If it's not still progressive, and there are the signs of it's deteriorating, then we need to do something.
Although I would think maybe now's the time to act, because I've got a number of patients that have had their left heart dealt with years ago, and now they've got bad TR, and their right heart's terrible, and it's just an awful way to go. While you've still got a right heart that works.
And also it looks like it's a mechanical TR, right? And
It's not functional.
It's not functional. What did you do?
Okay. I have one question. How can you evaluate the RV function in the patient with TR? We know that if the RV function is too bad, the result of the valve replacement is not so good. So do you have any number or method to evaluate this problem?
That's a tough one. I'm going to talk about it tomorrow, but we will talk about it. There is no perfect way to do it right now, unfortunately. RV strain seems to be a good way to look at RV dysfunction in TR. I think everything else is completely useless. TAPC is useless. FAC perhaps is better than TAPC and S prime, but other than FAC in our conventional indices, I don't think anything is reliable in TR. It's difficult. RV strain is emerging to be a good one. I'll show you some data tomorrow, and I think that seems to be, and it's easy to do RV strain. Unlike LV strain, RV strain is much easier to do, and I think it may ultimately be a good number to use. The problem is we don't have any outcomes data based on it. Everything is retrospective or observational data. Even ours, which is 900 patients plus, is observational data. We need some prospective prognostic data for RV strain. But I think ultimately that may be the way to go.
Do you think you maximize your medical treatment? Because from the list of medicine that you show, the patient has been quite...
There's not much heart failure here. I saw trace edema, right?
Yeah.
And you didn't see much. You're the expert. I mean, how much more you think it might help? I'm not sure it might help a lot more, right? Did she have heart failure symptoms? What did she have?
She had shortness of breath and
start to get swelling.
Yeah.
And neck vein is very enlarged, engorged.
Yeah.
Can you show your medication list?
Sure.
They look looks like quite a lot of medication you put on
Yeah,
this
but
patient.
Yeah, but the aldactone is not
The
under dose.
spironolactone was on 25, which is not a direct dose, and I'm not sure what's the ACE inhibitor for in this patient. Anyway, maybe hypertensive. Yeah.
How are the kidneys doing? She's got diabetes and...
Not so bad. I cannot remember the exact number, but that's okay.
Maybe the edema from the nifedipine. Yeah. So I don't know.
Thank you. Okay, anyway. After we introduce the options to the patients, she would like to go on something percutaneously. So, okay, what we did is we put the new valve to the tricuspid valve, and we put the 26 S3 to the tricuspid valve, and this is the result after implant the new valve. Okay. Yeah, and we sandwich the pacemaker. So, sorry? Yeah, and after we sandwich, we have to check the pacemaker function. And several days after we implanted the new valve, the pacemaker function, the threshold is rising. So we try to put the new one, but in order to prevent the pacemaker leads impingement again, so we put the leadless pacemaker to Harvey, and this is the final result. The grade is 4, and she's doing well right now.
Yeah, I hope you don't have to put another valve.
The only other comment that I would make is if you've
Yep.
got a patient who's going for tricuspid valve, if you think there's any possibility of them needing a pacemaker, any sign, you want to put the epicardial in there
Yeah.
the first time, which
Yeah.
is really easy to say.
Yeah, I do agree with you. I do agree with you, but
Your centers routinely check the tricuspid consistency, competency after they put the lead mask. Do they do that?
Yes, they
No,
always do an echo.
do that because they don't do it routinely here, and then I
We
don't.
do it routinely.
I would think it was a good idea to.
I'm yes, maybe good practice, but I'm not sure there is any data to support it. When it happens, it's really bad, but I don't think it is an epidemic of a pacemaker lead. Most people do it well. But if it ends up in commissure or it impinges on the anterior leaflet, that's the problem situation that it happens. I'm not sure what the guidelines say about echo after a pacemaker. I don't think it's in the guidelines. Maybe good practice.
We do
Maybe
it
good
for-
practice.
they do it because of the town, so they do it.
Oh, yeah.
It's a by-the-way thing.
Oh, yes.
That
Not
they do.
not
So they're not
protocol.
specifically
Yeah.
but because they do that, they should have that
And then you
information.
have less TR compared to.
I cannot tell you that because I've never compared it with another centre that doesn't do it. Yeah, maybe we could.
It'd be a good way to follow. Write up a paper.
I mean, that goes for transplant biopsies too, right? I mean, so the problem is how many echoes should we do in what situation, and what is the rate of pacemaker-induced TR? When it happens, it is uncommon, but when it happens, it's really bad because then your choices are very limited in what you can do for the pacemaker TR. That's the problem. I don't think that is why it is not in the guidelines. It's not like every pacemaker has TR. I think, yeah.
Symptomatic.
Yes, symptomatic TR is a different issue, right? I mean, you get some amount of TR in a pacemaker, so that's the reason why you don't. But it may be good practice to do it, and it depends on your center. I mean, they do so many pacemakers in our place. We're doing echoes on those people. We won't have to do anything else, I think.
Although I think the day will come when we don't put pacemakers through the tricuspid.
That's
I
true.
think it's inherently a really bad thing to do.
And
especially when
leadless
it's like-
pacemakers and all of that.
Exactly.
Yeah.
I think that would definitely help.
Okay.
Good case.
Thank
Well,
you,
thank
Dr.
you,
Kawai.
thank
Good case. Love it.
Okay, the last case. We have a lot of time, so we can just relax and discuss. Dr. Bandit will present the case. The theme is, when is it too late to intervene in regurgitation valve?
The TAVR case that you showed while he's setting it up, you don't have core valve here, right? Or you have core valve?
we have
Oh,
both.
No, it's also supraannular valve. That's why.
Sure, that's true. But I think we have.
I know.
Not
You don't have to explain that to me. I'm okay with
yeah,
that.
because-
I was curious whether you have.
We have a cover. Thank you. This is the last case. Is maybe is between the valvular regurgitation and the heart failure. The topic is too late to intervene about regurgitation valve. My case is middle-aged guy. He diagnosed dilated cardiomyopathy for 5 years. He has some comorbidity, the proximal atrial fibrillation, the diabetes, chronic kidney disease, dyslipidemia, and viral hepatitis. Past history, he has a recurrent heart failure hospitalization at least 2 times in 6 months, and now on resynchronization therapy. Last presentation present with acute decompensated heart failure. The medication before he admission, he is on the sacubitril valsartan, the 200 at the moderate dose, the 200 milligram per day. The bisoprolol is a very low dose because he can't tolerate it. When we tried it up, he have a heart failure. The spironolactone limit about the renal function. He is still on the diuretic include the furosemide and tolvaptan to control his congestion. The sound medication is oral anticoagulation, the amiodarone to control the arrhythmia. From physical first admission this visit, the physical examination is show the jugular vein distension up to mandible. The heart is dilated and TR and MR murmur were here, and he has a swelling both leg 2+ degree. This is a chest X-ray and show the cardiomegaly and CRT, no significant infiltration, suggestion of some pneumonia, possibly all of this is from the heart failure. The EKG show the Y-QS complex even beyond the resynchronization therapy. The blood tests show the acute kidney injury. The creatinine rise from the 1.5 to 1.9, low serum sodium, high proBNP, and elevated bilirubin, possibly from the congested liver. The other not significant. This is the echo. The echo show the poor LV function, dilated left ventricle. The mitral valve show thickening of anterior and posterior leaflet of the body and tip of mitral valve, and seems to be that the anterior mitral leaflet tip it point into left atrium. The aortic valve is look okay. The left atrium is dilated. The eye function may be fair. When you turn on color, we show the posterior dilatation, mitral regurgitation. I think this is moderate to severe degree of the mitral regurgitation. From the four chamber view, we show the all cardiac chamber were dilated, fair RV function, poor RV systolic function, and moderate amount of the pericardial effusion. When we turn on color, we show that the mitral regurgitation and at least moderate degree of the tricuspid regurgitation along the CRT lead line. This is a parameter of the echo from this patient when they admit due to acute heart failure. The ejection fraction is about 30 to 35%. The left ventricular dimension in diastole and systole is about 6/4.7. The mitral regurgitation ERO is 0.5. Regurgitation volume is about 56. Resistive pressure is about 60, and mean pressure by this diameter is just about 40 millimeter mercury. We done the right heart cath because the patient looks sick, but it's unfortunately that the result of right heart cath is very bad. Here's a cardiogenic shock. The cardiac index is 1.6, and he has a severe pulmonary hypertension due to pre-post mixed capillary cause. The pulmonary vascular resistance is about 8 Wood unit. We calculated the Euro score is in hospital mortality is about 5%, and the STS score about the mitral valve surgery is about 4% for mitral valve replacement and 2.5 about mitral valve repair because they have a heart failure and mitral regurgitation. So this is a question for the panelists. The first question is, do you think about the etiology of mitral regurgitation, the primary or the secondary? And the second question is, how can we deal with this case? Because he have a DCM for 5 years, mitral regurgitation, recurrent heart failure, even we try to titrate the medication, and now present with a cardiogenic shock. Thank you.
May I start? For the first question, can you go back to the echo, the parastonolone?
Okay.
Well, I think.
Wait for a few seconds, please.
Yep, that one.
Yep. Thank you.
Well, I think we can see that the mitral valve is not tethered. It's not, no tenting of the valve,
Yep.
which you would expect in functional AMR. So and there's a prolapse. I think I think the other panels agree, but there's a prolapse of anterior mitral leaflets, and so it's to me it's quite obvious. It's an organic component in there, definitely. The bad ventricle, is it from long-standing mitral severe volume load that we somehow underestimate in the beginning, or is it concomitant kind of a disease or not? But I would go for organic mitral regurgitation.
I think this is secondary MR. I don't think it's primary MR. I think that's a pseudo prolapse of the A2. I think there is some tethering of the posterior leaflet. It's not tenting, but it's tethered. It's that I think is causing the pseudo prolapse. There may be a combination of ventricular remodeling induced MR plus atrial fibrillation. I think the annulus looks big to me and the LA is big. So this is an atrioventricular MR type 1 and probably type 3B combined, which is a mixed valve disease, which you see common in heart failure, not uncommon at all in heart failure patients. So I think that is the etiology. I'll let first you go.
Yeah, look, I agree. I think like you, it's probably primarily functional, but there's probably more than one component to it. The thing that's going to make it, well, many things are going to make this case difficult, but it's just those leaflets look quite thickened where you might, if you were thinking of clipping them, where you might want to clip them, and that's of some concern. Like you might think this might be one of those patients that fits into the kind of COAP study, except the other thing that bothers me about them is their pulmonary hypertension, which is mixed.
Yes.
Thank you. And I think you're right that with atrial remodeling, then you won't have so much tenting. Then you will have more flattened, perhaps. Yeah.
Yes, I have more information because I'm not sure about the timing. So I had the TE slide. I will show you this multiplanar reconstruction of the transesophageal echo of the mitral valve because we're concerned of the primary or the secondary of the valve, like the of the panelist discussion. So this is more information about trachea, the mitral valve.
But what is it? I mean, I'm not sure what it is at this point. What are you thinking it is?
You suspect that there's flail leaflet?
I'm not so sure. Is it?
You could say, I guess, technically it's flail in that the tip is pointing into the LA, but I suspect that it has nothing to coap to because the posterior leaflet's pulled down. So it's a bit difficult because technically you're right, it's a flail, but I don't think it's necessarily part of that spectrum of degenerative. It'd be interesting to look at his old echoes, though, as you said, to see how things have transpired through time.
What did you think it was?
I think, yes, I think in our heart imaging it is maybe from functional because the mitral valve is dilated and the posterior restriction, like you said, even the tip is prolapsed. But we don't see some small chordae rupture or appendix.
Yes,
Yes,
the
I
ventricle
think
dilate.
the
maybe.
long-standing organic mitral
Yes, maybe.
would have some kind of functional mechanism to it.
Thank you.
In the long run, so it's going to be.
That's
gonna
the
be-
possibility.
Yeah.
It started off as MR and became heart failure afterwards.
Right.
But you
because
know if you look at the other echo.
No, because this is they sent from the other cardiologists. We don't have any echo from previously, so we just receive only the past medical history from the paper. Read the paper. There's a referral case and come to the heart failure clinic, and we fully new evaluation them. Okay, this is for more information. So we check.
So at this point, we can just say it's a mixed type.
Yeah, maybe mixed type. Yeah, maybe trying to analyze this.
I don't know.
Yeah.
Just
Okay.
before you go further, what do you think about the CRT in this patient? That the patient, the treatment that the patient has all along. Now she has CRT too.
Non-LBBB, right?
I'm sorry.
ECG is non-left bundle.
Yes. I will show you.
Yeah.
But it's already on CRT. Sorry that I can't bring the first EKG before they send to insert the CRT.
Yeah.
Sorry.
I know that the patient has CRT.
Yeah.
What do you think? Did this CRT working for this patient? When I look at this EKG, I say this is something. This CRT is not working. You're
Okay.
still left bundle branch pattern.
TR, it's not doing anything.
Okay, thank you.
So not just a raw echo. I think the EP has to adjust the pacemaker, whether the timing of it should be better than because this CYQS complex.
I think you should, that's an option, Orpan. But I also think this MR isn't going to go away with CRT. There is a structural element to it. I don't think it's going to go away. It's not a dysynchronous functional MR. It looks like there's something more to this MR. That's what I think. But that doesn't mean that CRT is optimal here. That CRT is not doing anything clearly.
I agree with you because the QRS is not right. Yeah, drive-in bandwidth pattern.
So I guess what you could do is try and manage him with IV dobutamine, try and dry him out, try and see what you're left with, and try and see if you can get him well enough to do anything else with, because it's not at the moment.
Yes, I agree with you. Okay, this is the. Okay, I have a question for you. When after we stabilize post-cardiogenic shock and the patient is recover from the heart failure and cardiogenic shock, what will you do about the mitral regurgitation in this case?
Well, it depends on how much MR is there after that.
Okay,
It was still severe MR?
just the severe MR.
Still.
Yes. Yep. Still have severe MR even we use inotrope and vasodilator. But okay, clinical is stable, hemodynamic is stable. Blood pressure is around, systolic pressure was 90 over 60 around here. Rate is about 90. Can tolerate some small dose of the anti-heart failure medication.
Yes, we would clip him. I mean, I
Thank you.
don't think there's much else to do for him.
Because I want you to discuss about role of surgical mitral valve replacement or repair, or the mitral valve clip, or the continue the some medication again. Okay, or let him do the transplantation.
Maybe
Oh, is the patient 56?
53.
53.
53.
if the patient failed a clip, then I think that's where what you'd be looking at. The size of that ventricle doesn't rule them out for a clip. I think it was 6 was the maximal. And the EF, for what it's worth, also doesn't rule them out.
35, 30, around 30 or 35.
Another option, if you place the clip in our center, we would do transcatheter mitral valve replacement.
We've
Wow.
done that
We
too.
wouldn't probably,
Yeah.
we would
Thank
do
you
a
so much.
TMVR as opposed to sending him for surgery kind of.
Wow, thank you.
And the advantage of that, we've done it with the 12 valve, the Intrepid, and the advantage of it is it's way easier than a clip, and the results that we've had have been very good, like just a trace of MR, but it is an operation. So it is that particular valve is transapical, so it is surgery, but it's quick and it's over within about 30 minutes.
That's a transeptal
That,
of Intrepid.
and there is, I've not seen that one yet. Well, that would be interesting.
We just started. We started transapical.
Yes.
It's part of the Apollo study. So the Apollo was written in a way that they would transition from transapical to transeptal when it becomes available, kind of thing.
That's a huge advantage.
Yeah.
Huge advantage.
Well, yeah, but
It's so big, though.
the sheath is like 34 or 4. I mean, it's like a mini cut down operation in the groin.
okay.
Instead of a heart operation, you have a groin operation.
Thank you. Thank you for the great discussion and great suggestion. In this, okay.
Mostly it's transapical.
Okay, I will show the clinical cause in this case. After the admit, we insert the pulmonary artery catheter to hemodynamic tune up. We use the inotrope and vasodilator in this case until his symptom is stable. He out of cardiogenic shock, and we bring him into this discuss about the heart team. The heart team so agree with you. We start the mitral clip first, and heart failure team listing him for transplantation because I'm not sure if we fail for mitral clip, you don't have any chance for the go to transplantation. So we try to urgency listing for the plan B, and we start the mitral clip for the plan A. Okay, we start the mitral clip. This is the mitral clip. This is 3D esophageal echo. I show you that if you see the anterior mitral leaflet, you see like a 2D picture. The anterior mitral is prolapsed into the left atrium. This is a explained image show the severe mitral regurgitation and mandible jet. And post clip we try to use the 2 clip. Okay. We try to use 2 clips and show that the degree of mitral regurgitation is very small when compared with before we use clip. Okay, and the mean gradient we concerned about the mitral stenosis post clip because we use the 2 clip. We check the mean gradient is about 3 millimeters of mercury. And after that, when we check it, we show you in the color 3D imaging that the degree of mitral regurgitation is very good. It's much better when we compare with before clip. This is a follow-up right hand cath during the pre-operation and during operation. The left atrial pressure and PA pressure is decreased. Okay. Yeah, this is a follow-up echo around 6 months after that. The LV function is the same. The mitral regurgitation look like decrease of degree of mitral regurgitation, you see, and the RV systolic pressure is decreased from 60 to 40. The mean blood pressure is sustained around 25. And very surprisingly, we can titrate up the anti-heart failure medication to maximum tolerated as patient as get. The sacubitril valsartan maximum dose, bisoprolol from 0.6 to 10 milligram per day, spironolactone is 25. We take off all of diuretics. Then the patient functional class is well. He can do anything. He can do at his grocery store. Okay, this is my case. Thank you.
Okay.
Congratulations. Beautiful.
Thank you.
With such beautiful results, I would think this must be an organic one that we correct rather than a functional one. Do you think so? Because it seems,
Even secondary, sometimes.
Even in secondary, you can get good results. I mean, I unless you're dealing with a large ventricle and a big annulus, that MR was interesting. There is a central jet, but there is a small medial jet. I was watching your post when you showed the pre-post kind of thing.
Yeah.
Now it may be. I mean, it's hard to tell I think this is truly a mixed disease. It's not just one or the other. I think it's truly a mixed disease.
And that is really common too.
Yeah.
When you're assessing a valve repair, it's really common. You find one mechanism, they have prolapse. Then you miss that they had restriction of part of another leaflet, and that can make a repair a lot harder. So it's quite common to have dual torsions.
the ventricle looks a bit, would you call that a non-compaction? It looks, the tuberculations look very,
Right. The left ventricle in the transthoracic echo look like a more tuberculation.
The last one.
Yeah.
Sometimes patients with heart failure, you see that.
Yeah, and
Yeah.
I know this is primary or secondary.
Yes.
It could be.
But my question is, are you happy with this? This is, you start to see the patient improvement, some remodeling. What will be your next plan for this patient? Because this will be temporary, patient still young.
Yeah.
You're waiting for him to get sick again and have transplant, or you want to do something right now? He's already start to show some remodeling of his LV. So what is your plan?
We will follow close clinical monitoring in the heart failure clinic. We don't discharge them because we fear about risk of decompensation of the heart failure. So he's still on the listing for transplantation.
That is smart. I mean, because he may still come to a transplant. The LV dysfunction hasn't gone away. That's always going to be there. I don't think that LV is going to recover because you fix the MR. That's why I think this is a ventricular MR rather than MR ventricle. I do believe this is that. That's what I think. I don't know for sure. But that's what I think. So I wouldn't take the patient off the transplant. He's 50-something, right?
53, right?
Yeah, it's far too young.
Sure, because
this cannot be a permanent solution.
Yeah, right.
Although what is coming is, if somebody had a clip and they are not eligible for transplant, for the sake of discussion, then you can remove the clips, transcatheter, and do a transcatheter valve replacement.
Good. Thank
So
you.
you can actually remove the clips safely.
Yep.
You can capture the clips back. But you have to put a valve in because you can't remove the clips and leave the leaflets there. It comes away with the leaflets, some part of the leaflets. But then you'll have to replace the valve.
When you remove the clips, can you do it even if you've been in for some time?
Oh, yes. So it's like we just saw it last week. It's like a little knife that cuts around it, and it basically captures it back into a thing.
Oh.
So it is a surgery, if you like. It's a percutaneous surgery. So you're left with holes, which means you have to put a valve in there. You just can't leave that over there. So
Okay. Yes.
So during the time of removing a clip, you have to get ready.
But I think transplant may not be a bad option. He's 50 something. I mean,
Yeah.
if that's what he needs, that's what he needs. If
Very good case.
Yes.
Okay.
Okay,
and
thank you.
Thank you very
Your
much.
discussion. Thank you so
So,
much.
okay.
Thank you.
I think all sessions should be like this, like 4 people talking.
We're having a good time. We're having a good time. Thank you. Thank you.
Very good. Excellent. Absolutely. Just